adoption sort of as an implicit need and platform to further the reach of implementation science in global health. So really, what does it mean to connect our research and researchers with those that use research or end users of research evidence? And then I'll end with some resources in implementation science in the global context. So just as a way of anchoring my talk and sort of as we think about what implementation science is, we all know that there's sort of this long and neglected bridge between proven interventions and their successful implementation in the field. And implementation science is really what is enabling us to build and strengthen that bridge. Next slide. So if we want to think about what is implementation science, it really is the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve our impact on population health. And I will say this comes from the National Cancer Institute at the National Institutes of Health. But just to say it's been a long road to sort of come to a consensus around what implementation science is and sort of the definition, but we'll use this as our definition for today, as I think it captures what we mean at the NIH. So the origins of implementation science came through the recognition of the gap between research and practice in healthcare. And moving scientific evidence into real world settings has traditionally taken a lot of time, really on average 17 years, which is really too long. While you may have done research, may have done the research and developed a scientifically proven intervention that's effective, practice, policy, or guidance effectiveness does not equal uptake, right? So implementation science is really focused on the how question. How can we move interventions, practices, and policies into real world settings like healthcare systems, schools, and communities disproportionately impacted by global health challenges. Next slide. So some simple ways to think about implementation science. While I've shared with you the definition of implementation science, this is a tool developed by Jeffrey Coran at the University of Arkansas, and it really boils implementation science down to this. Some things, really, the intervention or practice or innovation is the thing, the new vaccine, a new treatment protocol or therapy, or a new and revised clinical guideline. Effectiveness research looks at whether the thing works. Implementation research looks at how best to help people and places do the thing. Implementation strategies are the stuff we do to try to help people and places do the thing. And main implementation outcomes are how much and how well do they do the thing. So that's just one way of really simplifying what we mean by implementation science. So here we see that this is sort of the traditional pipeline of research. So we look on the left side at the sort of what, usually that's the intervention. We move into sort of how do we implement and what is the implementation strategy. But typically and conventionally in research, we look at the what and then look at the health outcomes. So if you press again for the slide, Tanya, you'll see it's animated. Yeah. So the core of implementation research is this middle area where we're looking at the implementation strategies, outcomes, and then service outcomes, sort of before we get to the actual health outcomes. That's the sort of meat of implementation science. So moving to the next slide, when we're doing implementation science, contextual factors across multiple levels could impact the uptake and sustainability of the thing that we talked about previously. So we need to think about barriers and facilitators to implementing the thing across the individual, community, organization, and systems policy levels. And I think what I would say is that context is really, really critical to implementation science in a way that it sort of is the anchoring determining factor. So importantly, not only do we need the intervention to cross multiple levels, but we also need multi-level implementation strategies to address barriers or leverage facilitators at each level. We also need to look at where implementation is taking place, right? An intervention addressing impacts, for example, on climate change in an urban setting may need to be adapted for a rural setting. The same thing with implementation strategies used to promote the uptake, scale up, and spread of that intervention. Those strategies need to be adapted too. And we also need to look at global context. Interventions and implementation strategies will vary between high-income countries and low and middle-income country settings always. And all of our work at Fogarty is really focused on the middle and low-income country settings. So importantly, not only do we need to consider context in implementation science, but we need to engage partners across multiple sectors, really. So we need to think about, for example, the education sector, healthcare services, environmental regulators or other regulators, potentially the built environment, government ministries and policymakers, community and community-based organizations, potentially transportation and access, and economic drivers of implementation in global health. So I want to look at an example from environmental health, and this I borrowed from a colleague at NIH, but I think it's a good way to think about sort of how we operationalize implementation science. So according to the World Health Organization, 2.4 billion people, most of whom are in low and middle income countries and poor, cook with biomass, so wood or charcoal, and kerosene fuels in inefficient stoves and open fires. In 2020, the WHO reported 3.2 million estimated deaths. The household indoor air pollution that comes from inefficient and dangerous fuels leads to heart disease, stroke, lung cancer, COPD. Women and young children have often the highest rates of exposure because they're gathering the materials for fuel, and they're often exposed to increased risk of injury. Methane and black carbon that are emitted are powerful climate change pollutants. So if we really think about the environmental health issue is household air pollution, or HAP. The thing that we talked about before is cleaner cook stoves or cleaner fuels, and that's like really the intervention that we're trying to think about. Effectiveness research would be testing if cleaner stoves and fuels reduce household air pollution and improve health outcomes. And they do, so we know the thing works, and that's often the case in implementation science. We have a proven intervention. The implementation research really is looking at clean cook stoves and fuels, the thing, were not being used or implemented properly. So implementation science can help us identify multi-level barriers, so cost, supply chain, technical assistance, and facilitators. And when we think about implementation strategies, we're really looking at testing multi-level strategies to promote uptake. So these strategies are the stuff we do as implementation scientists to help people and places use the thing, the clean cook stoves and fuels. And implementation outcomes are really thinking through how much and how well people use the clean cook stoves, the thing, looking at uptake, feasibility, acceptability, costs, sustainability, and appropriateness of those interventions, or that in particular, that intervention. So if we think about strategies, which is a really important factor in implementation science, I'm going to talk a little bit about one study called the Expert Recommendations for Implementing Change, or ERIC project, which identified 73 different implementation strategies that are organized by 9 distinct clusters or buckets that you can see on your screen. These strategies that implementation scientists study and use to help increase the uptake, scale up, and spread of effective interventions across multiple levels. So these are strategies that include things like interactive assistance or evaluative and iterative strategies. But how do you know which strategy or combination of strategies that you need, how do you know which one to use? These are helpful questions on the right-hand side of your screen can help. So you could ask yourself, what barriers are you trying to overcome at multiple levels, from individual to policy, macro levels? What resources are you able to leverage? Who do you need to engage? Will these strategies promote equitable implementation? And these are all critical questions in the context of implementation science. So if we want to think, sort of turn ourselves to implementation outcomes, while effectiveness outcomes can examine health effects and changes in behavior, implementation outcomes focus on things like uptake and adoption. So is the thing, the intervention, practice, or innovation being used? Acceptability. Do the person or place using the thing, do they like it? Feasibility. Is doing the thing practical in this community or setting? Sustainability. It's one thing to achieve uptake of the thing, but it's another to see if your implementation strategy helps to sustain the thing once the project ends. And is the thing still being used over time? And how do we think about looking at that? Appropriateness is really what is perceived fit of the thing, or compatibility with the setting. Fidelity really operationalizes, was the thing implemented as planned, or did the thing need to be adapted for this setting? Cost is really taking into consideration whether cost in implementing or using the thing is a barrier. And reach is really the absolute number, proportion, and representativeness of individuals willing to participate in the thing. Really, who's willing to try it? And these all come from Proctor. Again, these are sort of key experts in implementation science. So if we think about theories, models, and frameworks, they're really integral to implementation science. And there are three main types. There are many, many theories, models, and frameworks, but three main types that include process models, determinant frameworks, and evaluation frameworks that focus on implementation at multiple levels of influence. So process models include EPIS frameworks like this help to guide the movement of the thing into practice. So EPIS, for example, includes 4 phases: exploration, preparation, actively putting the evidence-based practice into practice, addressing additional barriers, and sustainment. So is the evidence-based practice fully integrated and monitored and able to be supported over time? Determinant frameworks like the CPEFAR, which is a very common framework in implementation science, contain constructs that impact implementation outcomes such as uptake and sustainability. So CPEFAR is comprised of multiple domains, including the intervention characteristics, outer setting, inner setting, and characteristics of individuals and process. And then we have the evaluative frameworks like REAIM that help researchers assess implementation success. So I'm moving very quickly, so apologies if folks do have questions, but I wanted to make sure we're all on the same page in terms of what we're talking about. So this is a helpful tool developed by Drs. Lane, Fall, Coran, and Baitis to see where your study may fall on the translation pathway. So I'll walk us through a few examples of funded grants moving along this subway line. And sort of generically, the red line is where your efficacy studies fall. So really, those studies are looking at whether the thing, the intervention, innovation, or practice is demonstrating that it works, demonstrating success really under ideal conditions. So we're thinking like RCTs here. The yellow line are where your effectiveness studies fall. So these are studies where we're asking, does the thing work in the real world? So does it work now that it's not being tested in ideal, tightly controlled conditions? So moving out of the randomized control trial. And then studies that ask implementation science questions fall on the green line. So in that sort of bin, we have hybrid studies where we look at effectiveness and implementation at the same time. And implementation studies may focus on identifying barriers and facilitators in impacting uptake of the evidence-based things. So studies of context or implementation science studies may focus on developing strategies or comparing and testing different ways of implementing the thing. So I'm going to shift gears. That was sort of my primer on what we're talking about when we come to think about implementation science in the context of NIH. So I wanted to just say that from the Fogarty International Center's perspective, we have been valuing implementation science since 2008. Next slide. And it's represented is one of the goals in our strategic plan. Importantly, and sort of focusing in on the focus of this talk, in 2012, we added a strategic priority that really underpins some of the collaborative work that I have done, which is really around the need to catalyze interaction between researchers, policymakers, and program implementers in order to promote uptake of evidence into global health policy and practice. And this is really the idea that we need to make deliberate and concerted efforts to bring users of research evidence into the research process, especially in the context of implementation science. Next slide. So just to give a sense of where I sit, I'm at the Center for Global Health Studies. Right now, I'm the deputy of Fogarty overall, but my previous role and current parallel role is as the deputy of the Center for Global Health Studies. And just to say, a large portion of our portfolio for CGHS is also around moving the implementation science agenda forward, really working as an innovative hub for models that do this. Next slide. So just to say what I mean by moving the implementation science agenda forward is that we do many projects that promote implementation science methods and frameworks, including thinking about whether and how those frameworks that were developed in high-income country settings are really appropriate and effective in low-income country settings. We do a lot of work around fostering dialogue about the implementation science agenda at NIH and beyond, and that also includes within some of our projects that I'll get into in a moment. And then overall, our projects are aiming to facilitate translation of evidence into policy and practice. And I should say the Center for Global Health Studies reflects the same disease agnostic status as Fogarty in general. So we do projects that focus on PMTCT, tobacco control, global mental health, childhood obesity. We don't have a disease-specific focus. So this is just, oh, you skipped a slide, I think. So we have many examples of our implementation science network experiments. And these are really the alliance model that I refer to in my title. And they're really, again, initiatives that aim to create a space for dialogue between users of research evidence and our implementation science researchers that we fund through NIH. But really the implicit need for there to be that dialogue. So we've done these sort of network experiments across various global health challenges. One of them focused on brain disorders and was linked to our brain disorders program. So really focusing on anything related to the brain. We have a network that's currently living focused around clean cooking implementation science. So looking at adoption of clean cooking technology. The third, these are sort of out of order, actually. The third would be our PMTCT Implementation Science Alliance. And the fourth is one focused on adolescent HIV implementation science. And I'm just going to go through them very quickly, but just to say that the crux of the objective really sits around the fact that policymakers and program implementers often don't speak the same language as researchers, as exemplified in this cartoon. So the first network that that I'm going to talk about is the Brain Disorders Network. And this was launched in Durban, South Africa in 2015. And we've gathered more than 50 researchers, policymakers, and program implementers in response to a request from our basically neuroscience grantees who said, we really want to learn how to get our innovations implemented and into practice and scaled. And they sort of were very hungry for the tools and methodological approaches that would help them do that, which are all implementation science approaches. So we held this launch meeting, and then we developed the brain, the implementation science learning collaborative, which really was the development of an implementation science toolkit. And then we held a hybrid training for the network. Next slide. So the learning collaborative is housed, the toolkit is housed on the Fogarty webpage, and it should just be noted that it's a very high level overview of implementation science and some of the tools that are used. It was developed by and for the neuroscience fields, which we call very upstream, right? They're not often in the more downstream implementation phases. They can be working on really the neuroscience level. But so these are the toolkit is very basic, but I think it gives a good overview of some of the approaches. Next slide. And these are just screenshots for you to be able to check out the toolkit, sorry. So the Clean Cooking Implementation Science Network was really launched to best understand how to improve the uptake and appropriate use of evidence-based cook stove and fuel interventions to improve health and quality of life of our populations in LMICs. It was funded out of the NIH Office of the Director and has been a really robust effort that has included a 15-member group that's grown over time, guided by a steering committee. And they, for example, the network itself has done a set of case studies and had other important outcomes. And really what I'm trying to walk through here is that these alliance models where we're really trying to strengthen collaboration among various stakeholder groups, can work and have worked across multiple different disease areas. Next slide. So the third example is the NIH-PEPFAR PMTCT Implementation Science Alliance. And again, this alliance has the same objectives as many of our other approaches at this sort of collaborative platform experiment. And really there was intended, and this was the first one that we launched ever, and that was framed by the objectives of facilitating dialogue and exchange of ideas between researchers, implementers, and decision makers, really as a working to strengthen and enhance communication and collaboration between these communities to enable more effective translation of evidence into health policies and programs, and to ensure that future research is responsive to the local context, as well as the fact that researchers really understand the barriers that are on the ground, real world barriers, and that policymakers and program implementers are aware of scientific evidence in real time. And then really just to create a space to think together about what are the emergent implementation science challenges that we need to, as a health community, overcome and address. Next slide. Just a quick note to say that our partners in all of these experiments span from the US government to LMIC, NGOs, and organizations to multilaterals like WHO. So we partner with a wide array of groups as a way to make sure that we're having a holistic view and being guided by perspectives that are beyond sort of the NIH-centric view. Next slide. And all of these experiments or initiatives we aim to have deliverables or impacts. So for the PMTCT Alliance, we did a 15-paper special supplement in the Journal of AIDS. We also leveraged the collective expertise and wisdom of the whole group to do a concept mapping of what are the biggest implementation challenges and solutions according to this community that we had brought together. And then, as many of you probably well know, the launch of the Nigerian Implementation Science Alliance sort of came out of the PMTCT Alliance, has been and is, I think, in its 8th year, and is really successful example of sort of a national initiative to try and move the implementation science agenda forward and build capacity. And then really we're aiming in all of these to just create and support sustained and new collaborations. Next slide. The fourth example is the Adolescent HIV Implementation Science Alliance, which we call AHISA. And this is the newest and probably most robust example of what I'm talking about. And this is an ongoing effort that was launched in 2017. So it's made up of 26 teams composed of researchers, program implementers, and decision makers representing 9 African countries and working across 11 African countries. So the network is really, again, there to enable research to be better informed by challenges on the ground and to encourage evidence-based policies and programs. And like I said, it's in its 7th year and has had some important impacts already. Next slide. We've been able to support local sustainable efforts, and in a way these are supposed to be modeled after NISA, but really in response to our members' desire to use implementation science to address regional and country-specific adolescent HIV challenges, and as a way to seed sustainable collaborations, infrastructure, and activities. We've been able to fund several local alliances that respond to the local contextual implementation issues, and really increase implementation science capacity across the region. So again, to be more explicit, the common local alliance goals are really around building a network of researchers, program implementers, and policymakers to create a forum really of peer-to-peer learning to enhance collaboration and to create a space where they're able to share resources, ideas, successes, and failures. Another key goal of these local alliances is to build implementation science capacity. So really, they've been able to lead locally tailored implementation science trainings, develop toolkits, and to engage non-research stakeholders. And then also, importantly, to support implementation science mentorship, which is often what we hear is missing from sort of the research field in LMSCs. They're also aimed at identifying evidence-based interventions to support response strategies. So really, and enabling exchange of information about success. And then again, enhancing translation of evidence into policy and practice. Next slide. So AHISA has already resulted in a number of deliverables and outcomes, and these include seminal publications and a supplement in AIDS and behavior with 14 articles on various aspects of implementation science and adolescent HIV. In addition, AHISA has informed the development of other funding opportunities at NIH. And members have also acknowledged the Alliance on successful research and grant applications. So some of our network members are already succeeding in other implementation science endeavors. We're also working right now on an evaluation to capture the extent of outcomes, including on policy and practice and collaborations, as well as stakeholder engagement. And this next slide is really just embodies a little bit of what we're trying to do. This is a quote. So the Zambian AHISA team enabled us to collaborate better with the Ministry of Education towards providing and reporting on health services coverage in schools and during community outreaches. It has also helped us appreciate existing research gaps to improve our programming. And that was a quote from the Zambian Ministry of Health. And we are just noting that this captures the influence that one of our local alliances has been able to have on policy programs. And we hope to hear more of this as the work continues. So again, this is just a cartoon to basically that embodies the fact that, anecdotal evidence isn't valid. Yes, it is. But really, when we think about bringing researchers and policymakers and program implementers together, they speak disparate and different languages. Next slide. Some of the enduring challenges. Next slide, Tanya. Some of the enduring challenges that we've heard and sort of over and over are what are the key barriers to utilizing scientific evidence to inform policy? And those are barriers that exist both on the demand and supply side. We've heard a lot about questions around what are the critical junctures at which researchers and evidence can most effectively inform policymaking processes. So in a lot of ways, we have different timescales for policymakers and program implementers from researchers, right? So what is the best way to reconcile those different timescales as a way to really leverage and use research evidence in a way that's timely? And again, related, what's the minimal criteria for determining scalability of research evidence? So given these different timescales, can we use anything shy of sort of the NIH gold standard of research evidence? Can we use interim results? And how do we really think together as a community about what that means and how to define what those are? And then what are feasible and valid methods to measure how well policies and programs have been informed by research evidence? So when we really try to look back at what's the return on investment for implementation science, I think it's critical that we figure out ways to really capture impact. So here I'm just shifting gears again to share some important resources. So the National Cancer Institute at NIH is sort of our academic hub for implementation science. So their link is at the top, but many other institutes and centers at NIH are using and supporting implementation science. The Fogarty International website is listed there. Next slide. There are many funding opportunities at NIH, but there are other funding opportunities that sort of go beyond NIH and are sometimes easier to obtain, and usually sometimes can open a door to obtaining more and more competitive funding. Next slide. For example, there's a trans NIH dissemination and implementation research funding announcement that's out. My colleagues David Chambers and Gayla Netta are the key points of contact there. Next slide. Every year there's a conference on dissemination and implementation science that always has a global track, and there are opportunities for sponsorship for LMIC researchers who successfully submit abstracts. So it's a good way to disseminate any of your implementation science research, as well as meet collaborators. And then there's important training materials online, and there's a lot of training online. But just to give an example, the Training Institute for Dissemination and Implementation Research in Cancer is open access, and you can see here, these are all modules. So if you were to walk through this, you would get a great primer on implementation science in general, but there's also the Global Alliance for Chronic Diseases has a hub. The University of Washington has an e-hub. So there's many places to find resources, which I think is excellent for the field and sometimes overwhelming if you're new to the research. This is again just the National Cancer Institute is our academic hub. They have a lot of resources on their webpage, including successful grant applications if folks were interested in funding. And then this slide is really just exemplifying there are some tools out there that can help you decide, for example, what model to use. And so there are many different ways to sort of navigate the space that can seem overwhelming. So there's, in summary, there's really strong support from Fogarty and many other parts of NIH for global implementation research. There's a lot of resources out there. You could subscribe to our Global Health Matters newsletter, where we profile new funding opportunities and successes that we see in the field. And I'll end with a quote. So there does not exist a category of science to which one can give the name applied science. There are science and the application of science bound together as the fruit of the tree which bears it. So just to say, we're continually learning how best to bring science to bear on implementation in the context of global health, and there's huge opportunity in that space. And finally, I'm very happy to answer questions, of course, now, but also feel free to reach out to me over email at any time. And with that, I will turn it over to questions.
Thank you, Rachel. Thank you so much. Very exciting, very interesting presentation you've made. So you already have questions on the Q&A. The first question says, are projects implemented from an evidence-based research?
If I understand the question properly, in the context of implementation science, usually what you're working with, right, is an evidence-based intervention that we know works, and often it's the barrier is in the implementation space. So if that helps, that would be the answer. So yes, it's along the sort of spectrum there.
I think just to add, to say something is that, for especially the way people think about this in Nigeria, is that the implementation science is not trying to find to see whether things work. That's not the idea. The idea is that they are taking something that there is already evidence that they'll work. So you know that mother-to-child transmission of HIV can be prevented. You're not trying to say whether can it be prevented, but you're not saying, now that we know how it's prevented, how can we implement that program to do that prevention? So you're not trying to find new things, because the idea is that if we can implement what we already know, that we can solve 80% of our problem in LMIC, that the ones that require new sophisticated thing will be the little 20%, but that what the problems are usually are things that we know already the solution, but how to make them either in the scale up or how to implement them or how to integrate them into the system.
Yeah, that's great. Thank you.
Yeah, so the second question is from Marvin, and he's saying, is there an implementation science framework that can focus on barriers and facilitators to intervention engagement?
So again, if I'm understanding the question well, so all of the theories, models, and frameworks are a way to help researchers think through what the contextual barriers would be. So if what the question is around stakeholder engagement, I don't know that there's one specific theory, model, or framework that focuses entirely on engagement, but I think it's sort of implicit in the science itself that one needs to be looking at engagement, because often, right, that could be one of the barriers or facilitators to implementation. I don't know, Etche, if you know.
So the way that traditionally we were thinking about it initially is something like REM before they went to REM 2.0. So REM was seen more at an outcome measure for implementation science. So it really didn't focus much on determinants. In the REM 2.0, they went back to do that. So we usually refer to things like EPIs as a determinant framework, because it largely focused on the exploratory phase, the areas where the preparatory phase, where the engagement and getting to find out things like readiness, implementation readiness. So you want to implement something on primary healthcare facilities. You want to engage those people in the exploration page. In the preparatory page, you want to find out, are they ready for this implementation of this? So Nigeria is adopting a HPV vaccine, and you want to start the HPV vaccine, and you want to put it, for example, in schools. that you want to, because you want to do HPV vaccine at a young age of 9, 10, and 11. So you want to put it in schools. Then you want to look at the schools where you want to implement this and see. So there are certain of them that you have more framework focused on the determinants, so the barriers, the challenges, the engagement at that time, and there are ones that are focused also on the outcome that comes from implementation measure like the, but all of them now do touch those things. So what I usually tell people is to pick one of them that you feel easy with, you have a mentor. I always like to, so most people will tell me, why do you always use EPIs? I use EPIs because Greg Aarons worked with me a lot. So we have come to know very much about it. I also use REM because we also work with the team. If you remember last month in June, we brought all of them together to go through all of these frameworks to be able to, those slides are still available at our website. So you can see each of the framework. And I think, Rachel, there is a website where you can actually go, that you pointed out, where you can actually see the work you're doing that will help you pick the right framework. Because there are so many of them that website has been very useful for people in considering which one to use for your determinants and which one to use for your outcome measure.
Yep, exactly. And those websites can be, they just sort of help you navigate in a space where there's lots of options. So,
and if you have challenges with it, that is one of the things that we got from the speakers in June. So if you have a problem with the Cypher, you have a problem with REM, you have a problem with APs, the people who develop them are willing to help people from Nigeria to be able to guide you through what it was intended for and how intended you can use them. So if you do have a problem, please do reach out to us and we can connect you to those who develop that, and they are willing. And that's a commitment they made at that meeting, that they want those things to be used more and more in LMICs, and to be able to use that, they wanted to be able to guide and protect and provide that guidance for you during your development of. I think while you are writing the proposal, you should actually engage them because it helps you to understand what you're developing. Thank you.
Yeah. Okay, so the next question is from Desmond, who's thanking you for the presentation. He says, but however, you said implementation science focuses on how well they do the thing, which makes it different from monitoring and evaluation. And so he says, what makes it different from monitoring and evaluation, since monitoring and evaluation also focuses on the efficacy of a program or project implementation?
I mean, I think it's a great question. And I think certainly early on in the growth of implementation science, there was a lot of discussion about, people saying, I've been doing this forever, you're just putting a new name on it. And I think there's some of that out there still. I do think that monitoring and evaluation is quite different. I think implementation science is like a really robust way to think about all of the things that can happen in the context of implementation. So really thoughtfully systematically going through what are all of the factors that might be affecting implementation, where evaluation might take a different angle and not look at all of those factors. They might look at whether and how a program works and sort of the contours of that. So I would just say that implementation science is a more rigorous and robust way of looking at those implementation factors.
So the way I want to add a little thing to be able to think of this, because you're right, these things are usually a spectrum. So they are a continuum of the other one. I always say that people who are or who have experience in measurement and evaluation are in the right spot to engage in implementation science and implementation research, because they have a background knowledge enough to move this there. The difference, though, is that implementation science is focused more on the process itself. The process is important. So it is not enough that people adopted cervical cancer screening. You want to be able to find out why did they adopt cervical cancer, because you want to be able to repeat those experiments. You want to be able to repeat it in another environment. You want to be able to scale it up in another environment. Most of the time, people who do measurement and evaluation are focused on, for example, we are focused on in Nigeria, in Benue State. What happened in Benue State? What did we get HIV screening done? Did we, so the outcome is there, but the outcome is limited in a way that reproducibility is not that common with most measurement and the monitoring and evaluation process. So it's limited to that concept, but the implementation science gives you an idea where you actually find out why, not only you say how are they doing, but also you understand if people adopted this, why did they adopt it? And that's why sometimes you see that implementation science have what will I say, a mixed method approach where there's a quantitative part, but also there's a qualitative part where you actually interview people who are involved in that process to gain, so say you screen for HIV. Why did you screen for HIV? You did not screen for HIV. Why didn't you screen for HIV? Because if you understand why people who screen and why people who didn't screen, then you are more better to inform the program that you develop than just looking at, okay, these people screen, done with them. Let's find out the people who did not screen. You want to understand from both sides and be able to join those in building a better program. Thank you.
Okay, thank you, Prof. So the next question says, what's the difference between implementation science and community-based participatory research?
So I would say that they're very different, completely different, but related. And I think that community-based participatory research could be an approach in the context of implementation science, but community-based participatory research could be any kind of research where sort of anchored on engaging community. While I think that's a critical element of implementation science, it doesn't, CBPR doesn't necessarily lay out all the contours of understanding implementation challenges. So they are quite different, but related. And you'll see on the Learning Collaborative Toolkit, we sort of walk through CBPR as an approach that's important and related to implementation science.
Okay, then Mohammed is asking, he's saying, thank you for your very lucid presentation. How bad is the gap between available evidence and implementation?
So I'm not sure one could answer that like completely globally, but I think often, and this is a change, it's changing and it's dependent on the specific disease area that we're looking at. But I think there is often a gap between effectiveness and efficacy research and then implementation research. So we have this evidence that something works, and we don't see, for example, adolescent HIV, we don't see, lowering rates of HIV. Why is that? We know how to, we have prevention strategies. So it's really trying to dig in and understand, why do people not use the evidence-based interventions? So there often is a gap. And I think if implementation science is the tool that would identify and basically interrogate that gap and try to figure out what are the ways to understand this better.
Okay.
So if I just add a little bit to that, to say that, for example, HIV has been one area we have gotten some development and we have catching up a little bit. I remember things like a test and treat. When we find out that test and treat was working, and we moved immediately to option B plus, where we started treating because if you remember where we started, we were treating only women whose CD4 count were less than this, and those things evolved quickly as the evidence came in. And then it was one of the places I saw a quick uptake from evidence to implementation, and those implementation, because when you also come implementation, is like immunization. One of the things that is very important in implementation science is policy. That's why we look at policy implementation, because you can mandate, which is not always possible, but when you can mandate vaccine, or you can mandate, for example, if you are using PEPFAR funding, then if you identify a woman with HIV, you have to start them on treatment within a certain period. So those things increase the uptake of PMCT and things like that. But what you still have been said, even after we're doing those things, why do we still have children born with HIV? For example, in Nigeria, we dropped from 75,000 children born every year to 25,000. But you would think that we should be getting to zero because of all the resources that have been poured into Nigeria and all the manpower development. And we started this in Nigeria in 2004. So we're talking about close to 2004 to 14 to 24, almost going to 20 years next year. So we have had a place where if we cannot stop PMCT, I don't think we are really going to be able to succeed in any other ones because they are more difficult. The PMCT is actually the easiest one that we can. And we have seen some countries have achieved that. So one of the things in implementation science is to understand why are we not getting to the end? Why are we not getting to zero? Why can't we turn off that tap? And that's where implementation science, in my opinion, for example, in PMCT remains, to find out what is those remaining things. We've been able to get, option B, test and treat. We've been able to continuous treatment even after the women have delivered, so that by the next delivery, their viral load is down, all the things we have put in, and we still have children being infected. Why? So that's some of the things implementation science, in my opinion, are the kind of questions that we still need to answer through implementation science.
Okay, thank you, Prof. So we have just 5 minutes to the top of the hour, and we have 5 questions, but I think I'm just going to take one question from the 5. And that question says, do you have any resource for implementation science research in the area of rehabilitation medicine?
So I saw that in the, I saw that question. I do not actually. And interestingly, that's sort of a, from the NIH perspective, that's a bit of a trailing focus, meaning we don't have a ton of research and or funding in that space. And I don't have an idea of where there might be other funding. I can think about it though, and certainly share with others if I come across anything, but off the top of my head, I don't know of anything.
Okay,
so someone's asking for okay, go ahead.
So now I wanted you to look at that anonymous attendee posting, because this is something that is very, very well.
The last question, right?
Yes, the Fogarty has done a very good job. The WHO has done a very good job. And we have done also, I would say, in NISA, we do this every week, every month. We bring in a specialist to be able to talk to us. A lot of adult learning, as we know, is self-driven. And like Dr. Sat said, if you really go out in the internet, you will see she put a lot of sites there. All those sites she put in there are free. But you have to do a self-learning. That's the difference with them. A lot of them are self-learning. So there is not a classroom for you to come, because classrooms begin to become difficult. But what people has done is that they put resources out there on the internet. So if you Google the internet, you can see, go to TIDR, the place, you go to the NCI. It told you that NIH has NCI as their body. If you go there, they have tons and tons of lectures that is out there. They even have, if you're interested in grant, they've been successful, samples of them. So these things are available. The difference is that sometimes the way we learn in Nigeria has always been some professor is talking and somebody is having a pen to take notes. But in this case, these things are out there. You have to get them. But if you are finding it difficult to find resources, send me an email. And Antonia will give you an email at the end. You can send it, and we direct you to where you can find them. There are so much information out there that if you truly want to advance yourself in implementation science, you can freely, for free. So that's the email here.
You're right.
Let us know what resources that you're, and if we can't find it, we'll go back to Rachel. And also, she has an email there. You can write her directly also, and then be able to find that. But if you want us to guide you through it, we will guide you through it and show you where the resources are. Even PowerPoint slides, all the lectures.
Free,
so they are
free
all
resource. They're free. There are tons of them out there.
Yeah.
Yes, thank you. Okay, so Rachel, did you want to add to that?
I would just say, I would agree that there's a lot out there. And I think what you miss because of the online resources are free and they're not curated or sort of chaperoned by a human, I think you sometimes miss the ability to interact and ask questions, or if you have a very specific project you're trying to work on or frame, it can be hard without the sort of mentor piece. And I think one of the things that I would recommend is really exploring all of those free resources, and then keeping a list of people that have offered their email, like me, or if there are people associated with some of those free resources, reaching out and seeing if you can get someone to have a conversation if you have a very specific sort of deep set of questions.
And if you remember, if you go to the implementation framework, we brought all of them in June. We still have that on our website, and they actually offered their slides also for you. They offered their emails for you. So if you really have, I think it doesn't make sense for you to go to ask some questions that you can find on I don't think it's the best use of their time. So I think you should use the resources that are available, get yourself up to some information enough. Then let's say you're now working on a project and you're trying to work on REM and you don't understand REM. The person who developed the REM, they were in this meeting and they said, we will help you and mentor you. I asked them openly and they said, we will. So if you're having problems to reach them, let me know and I'll go back to them with my hands begging to say, you promised to help us to do this. Can you help this person? But you can't just go to them without getting some of the tons of things that are out there. Then that becomes intellectual laziness. So I think you should get some information that is available out there first so that when you go to them, you have pointed use of their time and they will help you.
Yes, exactly. So I think this is a good place to end it. I want to thank you so much, Dr. Rachel, for being with us and giving us this wonderful lecture this morning, afternoon, evening for the rest of us here. And we would like to say thank you so much. And we hope you come and give us another lecture some other time. And thank you.
Thank you for having me. It was great to be here.
Thank you. Okay, so everyone, thank you for joining and see you next month with another exciting webinar. Bye-bye from every one of us. So don't forget to check out the links on the chat. And then, of course, you have Rachel's email. You can send her email. You can send our director for the Center for Translation and Implementation Research, Professor Echezona Ezanolo. You can send him an email. I have that on the chat. And see you next month. Bye-bye.